Welcome to my video lectures. I am Dr. Malaku Tamaskan. In this lecture, we will see how to take a clear and perfect medical history. So, if you want to be a good clinician, stay tuned till the end. These are the usual sequence of events undergone when a patient comes for medical advice. A clinician who takes appropriate history and physical examination can achieve 80% of the diagnosis. So after taking proper history and physical examination, problem list and differential diagnosis will be set. Then after, specific and relevant investigations will be sent to confirm or refute the possible differential diagnosis. Finally, diagnosis will be confirmed and treatment is initiated as soon as possible. What are the preconditions for history taking? Patient safety and confidentiality. Once you assure their safety and confidentiality, they will tell you a complete history and cooperate during physical examinations. And you should follow infection prevention precautions in every step. Make patients comfortable. You can make patients comfortable by showing respect through addressing their title, by giving warm greetings, by reassuring your activities will not impose any complication to their health, and so on. Be a good listener. Being a good listener is an invaluable skill for history taking. Let me tell you the tips that boost your listening skill. The first one is have a good eye contact. Be careful while taking notes in order not to compromise your eye contact. So don't focus on your notebook. Second, don't interrupt too early. Just let patients to talk as much as possible. If you interrupt frequently, they will not finish what they started to talk, and this will create incoherence in your history. Third, paraphrasing. Restate what the patient said by your own words. Fourth, summarizing. Pull together the main ideas of the patient. The last and the fifth one is questioning. Challenge the patient to think more and clarify things. Don't be judgmental. You should act professionally and be empathic listener. Patients have different degree of complaints because of their difference in pain threshold, psychosocial support, and living conditions. For example, a female model with mild acne vulgaris might have the same degree of complaint with a farmer presented with melanoma, so don't react with patient's complaint. Non-verbal communications. These are as important as verbal communications. As a clinician, you should observe the patient's non-verbal communications while concentrating on listening. A patient with burning type of chest pain might rub his sternum or make a fist and squeeze it to describe his angina. And also, it helps to understand patient's mood. Open-ended versus closed-ended questions. Open-ended or indirect questions are questions which their answer is not limited, whereas closed-ended or direct questions are questions which their answer is bounded or limited. For example, if you ask your patient, how do you feel today? Is open-ended question. But if you ask, do you have a chest pain? Is closed-ended question because the patient will reply either yes or no, so it is bounded. In the first phase of history taking, it is advisable to use open-ended questions to gather as much information as possible. But when you want to ask specific issues or clarification, closed-ended questions are preferable. Positive versus negative findings. Negative findings are as important as positive findings. If you got negative findings, no further inquiry is necessary. But if you got positive findings, further characterization is a must. This is the drawback of many medical students. They are talented to mention many positive and negative findings, but they lack characterization of their positive findings. For example, for a patient presented with diarrhea, the absence of vomiting is a negative findings, but the presence of abdominal pain is a positive finding, so you should ask detail about the abdominal pain. Therefore, mentioning positive findings without characterization is equivalent to not taking that specific history. Disease-centered versus patient-centered approach. Disease-centered approach is when a clinician uses direct questions to confirm the diagnosis of a specific disease, whereas patient-centered approach is when a clinician uses open-ended questions to hear all problems of the patient. For example, In a community with monkeypox outbreak, you might focus on specific signs and symptoms relevant to the diagnosis of monkeypox. So this type of approach is obviously disease-centered approach. Components of health history. A complete health history contains identification of the patient, previous admission, chief complaint, history of present illness, past medical and surgical history, a review of systems, personal and social history, family history, physical examination, and finally, assessment. The first one is identification of the patient. It gives full information about the patient, and it is a demographic data sufficient for epidemiologic evaluation. Identification of the patient contains name of the patient, sex and age, address, marital status, level of education and occupation, religion, date of admission and date of clerking, ward and bed number. By using these informations, you can narrow your differential diagnosis. For instance, a 70-year-old male patient with difficulty of urination and a 50-year-old female patient with difficulty of urination have different differential diagnoses because of their age and biological difference. A febrile patient from Addis Ababa or Devra Bran and with the same complaint from Humera have not the same differential diagnosis because of the epidemiologic variation from place to place. The second one is previous admission. It is a list of hospitalization in order of their occurrence, whether they are related to the presenting complaint or not. So it contains date of admission, name and address of the hospital, diagnosis, treatment, and outcome. For example, in 2014 Ethiopian calendar, University of Gondar Comprehensive Specialized Hospital Gondar, severe malaria, admitted for 5 days and discharged improved. So this is a precise description of the previous admission. In case a patient doesn't know his diagnosis, you can use specific symptom or signs that lead him to admission. If detailed description is necessary, it might be recorded under the past illness. If the previous admission is related to the presenting complaint, it should be recorded under history of present illness. For instance, a patient who underwent laparotomy after sustaining blunt abdominal trauma might come with incisional hernia. In this case, the presenting complaint, obviously incisional hernia, is directly related to the surgery despite the presence of many contributing factors. So you should put his previous admissions for surgery under the section of history of present illness. A non-cardiac patient for the past few years with multiple previous admissions might come with exacerbation of his symptoms. So as to make his history coherent and understandable, you have to put the previous admission under history of present illness. The third one is chief complaint or presenting complaint. It is one or more symptoms or concerns that make a patient to seek medical care. You can ask with simple questions. Tell me what brought to this. Then the patient tells you the reason why he came. Whenever you write a chief complaint, it should be simple, brief, and with duration, like cough of 3 days duration, diarrhea of 2 days duration, and so on. If there are more than one complaints, they should be listed in order of their occurrence, like cough of 3 days duration and shortness of breath of 1 day duration. The fourth one is history of present illness or HPI. HPI is a further elaboration of the chief complaint. So starting from the time when the patient was perfectly well, you inquire the sequence of symptoms and events. So in this section, you should describe the date of onset, mode of onset, course, and duration of the chief complaint. After addressing the chief complaint, you will ask associated symptoms, aggravating and relieving factors, treatment outcome, if any. Because some patients might have a referral, so knowing the outcome helps you to adjust your own management. Then finally, you should mention relevant positive and negative statements. I will elaborate the chief complaint. The chief complaint is cough of 3 days duration. Then Mr. X is a 30-year-old male patient who is relatively healthy 3 days back, at which time he experienced cough. The cough had incidence onset and gradually worsened. It is productive of whitish sputum. Associated with this, he has intermittent fever, fast breathing, and shortness of breath of 1 day duration. The cough is aggravated with cold weather and exercise, but relieved with rest. He was referred from a nearby health center for better diagnosis and management after trial of antibiotics. Then you will mention possible positive and negative statements, and finish the HPA. If pain is a symptom, you can characterize using the mnemonic PQRST. P stands for position or site, where is the pain. Q stands for quality or character of the pain, whether it is aching, burning, colicky, and so on. R stands for radiation. Does the pain radiate to some parts of the body or not? For instance, a chest pain secondary to myocardial infarction might radiate to the left shoulder. S stands for severity. Obviously, it is difficult to assess the severity of pain as it is highly subjective, but you can grade using the severity scale from 1 up to 10. 1 representing mild pain that rarely noticed, and 10 for the possible worst pain equivalent to labor pain. After stating this, ask the patient to rate his pain. T stands for timing. The other holistic mnemonic is Socrates. S stands for site or position of the pain. O stands for onset of the pain. C, character or quality of the pain. R stands for radiation. S, associated symptoms. T, timing of the pain. E, exacerbation and relieving factors for the pain. S stands for severity. Using these two mnemonic, you can characterize pain or possibly any other positive findings. Past medical and surgical history. In this section, all previous illnesses and operations are recorded in detail. So the importance of mentioning past medical and surgical history is to understand the pathogenesis of the presenting complaint, as it might be acute exacerbation or complication of chronic illness. You will ask history of diabetes mellitus, hypertension, asthma, jaundice, epilepsy, tuberculosis, allergies, and so on. Review of systems or functional inquiry. It documents the presence or absence of common symptoms from head to toe. In other words, it is a checklist of symptoms not already discovered. Suppose you are taking a history from a patient with thyroid cancer. Obviously, you will focus on the lymphoglandular system in history as well as on physical examinations. Unfortunately, the patient might have cardiac complications. So, during the review system, you will not miss his cardiac complications. It will guide your physical examination because you will concentrate on systems with positive finding on the review systems. For example, in cardiovascular system, you will ask common signs and symptoms such as chest pain, cough, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, palpitations, ankle swelling, and so on. Personal and social history. In this part, you will ask the lifestyle of the patient starting from his early development. So, the aim of asking the patient is to find out possible risk factor for certain diseases. So, you should ask socioeconomic status of the patient, occupation, hobbies, history of alcohol drinking, history of smoking and drugs, and so on. Finally, family history. It gives clues to possible predisposition to illnesses. It tells the reason why a patient anxious about a certain disease. A patient who lost her mother due to breast cancer is highly concerned about breast cancer, as it is a familial disease. And ask the health status of his family. This is all about history taking. If you have any question and suggestion, please write in the comment section. Thank you.